Very good afternoon. Vanakkam Chennai, and this is probably the last session before we break. It's great camaraderie among all of us. I've met some of my old classmates, some of my friends. It's been a great outing. Thank you, Parag. Thank you, Rami, for putting a wonderful program. And coming to the last session, I'm going to talk about tranexamic acid. I think there's a lot of controversies, but I'll just share with you what I've done over the last 1 year. It took me a long time to actually digest tranexamic acid, although it's been in the market for the last 15 years. And interestingly, on 2 days ago, I was with Gary Hooper and his wife, and we were just discussing tranexamic acid, and she said, I don't know what you guys are talking about. I've been using this for the last 10 years or so without any problems. I just don't understand the fuss that you guys are putting in. And I realized I spent 1 whole year trying to fix this up. But anyway, I'll see what I can do. That's a good knee, and that's what we want, and that's tranexamic acid that we have. And that's literally bloodless knee because I don't use, okay. Now, I think this is a very important statement. Before surgery, everything that we tell the patients is science. We talk about the science of surgery, but after surgery, everything that we do is defense. So I think that's something that we all have to remember because this is very important. And with that, I come to the background of this. Now, total knee is the most commonly performed elective orthopedic procedures, I think, all around the world. And total knee provides significant pain relief and improvement in the quality of life. I'm sure you all would agree with me. However, TKA is not without complications. Now, we have significant blood loss that sometimes require blood transfusions, and most of these bleedings from total knee arthroplasty are probably because they may be hemophiliacs or anticoagulant issues or cirrhosis. And surgical techniques are the most primary importance because our bone cut, soft tissue dissection, and also the blood vessel injury that we can have, especially from the lateral and medial geniculate vessels, and also from the PCL. So tranexamic acid is not engraved in stone, but it's something that can help us while in the surgical field. Now, the transfusion rate in TKA over the worldwide on a lot of papers are about 30%, and that's coming down of late. And the transfusions are normally associated with the risk. That's infection, acute systemic reactions, and death. Now, transfusion also increases the rehabilitation time. It lengthens the hospital stay, much to the dismay of the patient and also to the surgeon because the cost goes up. And the cost to the patient is something that of late, the insurance companies don't cover as much as what they used to do, so sometimes the cost actually goes back to the patient. Now, controlling blood loss during and after surgery is an important goal to achieve good results in TKA and hence tranexamic acid during surgery. Now, there's a lot of work that has been done by Rosoli and all on blood management after total joint arthroplasty in the United States over a 19-year follow-up trend analysis, and that shows that the RBC transfusion is an independent predictor of hospital mortality. Now, a quick recap on the pathophysiology of tranexamic acid. It's a lysine analog. It's an inhibitor of fibrinolysis, and it's normally just IV tranexamic acid. It helps to reduce transfusion requirement. The dosage varies, but it's standard about 10 milligrams per kg body weight. I normally just give 1 gram at the time of skin and 1 gram 3 hours later. That is when the patient is in the post-op zone. And I only use tourniquet during cementing and nothing else. And of course, the tranexamic acid should be given before cementing if you're delayed in giving. Tranexamic acid also inhibits the plasminogen activation, and the plasmin cleaves with the fibrin clots. I'm sure you know all this. And it allows the clots to dissolve. So inhibiting the conversion of plasminogen to plasmin, tranexamic acid allows mature fibrin clots. Now, the coagulation is continued uninhibited. And you must know that tranexamic acid has a very short lifespan that is about 2 to 3 hours, and it's excreted in the renal by the kidneys in 24 hours. Now, that's the pathway, and that's where tranexamic acid would work. Now, that's a very bloodless film that you get in surgery nowadays. The tourniquet is there, but the tourniquet is only kept during cementing. So this is just after exposure, and you can hardly see there's any bleeding. Now, there are some concerns when we're using tranexamic acid. You've got to make sure that this patient does not have previous histories of thrombosis, pulmonary embolism, or renal failure, because this would be patients that you would not want to use them. Now, there are a lot of studies that have been shown either supporting tranexamic acid or against tranexamic acid from Shandong and Cochrane and Crash, Aish, Daria, Hipala, and Ishida. Ishida interestingly showed that intra-articulary tranexamic acid application not only reduces blood loss, but also reduces joint swelling, which actually helps in the post-op management. But generally, I think everyone is in support of using tranexamic acid in joint replacement. Now, over the last year, in 2016, I chose 55 patients. The high-risk patients were excluded. Those with CVA or had post-stents or renal impairment were all excluded. I took 20 without tranexamic acid and 35 of them with tranexamic acid. Female-male ratio was 3:2. Average was age was about 60. Most of them in Malaysia at least have some amount of comorbids. They would either have diabetic or hypertension. And tourniquet was only used on cementing. I used the tourniquet just for 20 minutes because for some reason, the cementing techniques today, although we hope that the cements would get hard in 10 minutes, they actually take anything between 15 to 18 minutes. The blood loss in tranexamic acid and versus non-tranexamic acid, you can see there's a variant. And 76% of those people with tranexamic acid and 36% did not have a blood transfusion. Now, I normally just group and hold blood in all my TKAs, but not in hip replacement. And the mean transfusion amount was about 270 milliliters. And the lesser post-op pain was with the tranexamic group. Now, if you look at the blood loss, with tranexamic acid, there was about 528, and the hemoglobin drop was about 10 to 25 grams per liter. Patients who received tranexamic acid had a lower amount of blood loss. That's a p-value of 0.015. And the rate of transfusion was not statistically lower in the tranexamic group. Was lower in the tranexamic group, and less post-op pain. Whereas with the non-tranexamic acid, the blood loss was between 800 plus. The hemoglobin drop was between 20 to 50 grams per liter, and the RBC transfusion rate was about 10 to 69. Post-op pain most compared to TXA with the pain score. Now, with transfusion, we have a lot of risk, that is the disease transmission, transfusion reaction, clerical errors, infection, and myths. In our country, we have a lot of subsects of religion where transfusions are not allowed. And of course, with transfusion, you have poor quality, the effects of hemoglobin, the increase in the length of stay in the hospital, and of course, costs. And to discuss, I think we must avoid in patients with VTE, embolic CVA, and coronary stents. I mentioned that earlier. Some meta-analysis works to help tranexamic acid works to reduce blood loss. These are some of the meta-analysis supporting that. And the controversies that I just want everybody to just think. I use intravenous, I don't use topical, but from the topic that we had yesterday, I heard some of them were actually using topical and they found that it was good. Now, in conclusion, I'd like to say that based on the current evidence, I think it is safe. Tranexamic acid can reduce the need for transfusion. It reduces total blood loss. Post-op pain is reduced. There's no occurrence of DVT in what I've seen. And there's administration is recommended routinely in either bilateral or unique TKA. And with that, ladies and gentlemen, thank you very much. And thank you, Chennai. Thank you.